Good afternoon, everybody in the virtual sphere. My name's Chris Tremonti. Welcome to DARIA for October 2023, the Drug and Alcohol Research and Innovation Advanced Learning Network. We have a very full program and three excellent speakers, so I'm going to get straight into it, which should allow some time for everybody, for the late stragglers to get in. So this month's DARIA is on overcoming barriers to women accessing treatment for methamphetamine use, in particular focusing on the WOMA study. And we're joined by Professor Nadine Ezard, Dr. Suzie Hudson, and Anna McVinish from St Vincent's Hospital. If I can start with introducing Nadine, who I believe is going to speak first. Well, actually, I'll come. Well, I'll speak first about Nadine, who's the director of NCRED and the clinical director of the Alcohol and Drug Service at St Vincent's Hospital here in Sydney, home to one of New South Wales' first stimulant treatment programs. Nadine has 25 years experience in the addiction medicine field and has received multiple accolades, including Commonwealth Scholarship, Australian Financial Reviews, 100 Women of Influence. And Nadine's body of peer-reviewed research involves building the evidence base for improved health interventions for marginalised populations. And her current research focuses on working with people who use stimulants to develop new and effective interventions. Nadine is, of course, a doctor as well. She's a registered medical practitioner and a FATCHM, fellow of the Australasian Chapter of Addiction Medicine and Royal Australian College of Physicians, and has worked for the WHO, the United Nations High Commissioner for Refugees, and the UN Office of Drugs and Crime. Anna McVinish also works here at St Vincent's Hospital and is a clinical nurse consultant working in alcohol and drugs at St Vincent's Hospital. Prior to nurse training, she worked for 10 years in the specialist homelessness and community sectors, supporting vulnerable populations with complex needs. She also works at the medically supervised injecting centre in King's Cross, and recently received a Churchill Fellowship to investigate injectable opioid agonist therapy implementation at multiple international sites with a view to best harnessing her findings for the Australian setting. And finally, Dr. Suzie Hudson is a mental health social worker who has worked in the AODA mental health and forensic mental health fields for over 20 years. She's clinical leader and current clinical advisor at the Centre for Alcohol and Other Drugs at the New South Wales Health. She also works as an accredited trainer, researcher, and therapist in the community. Before I go too much further, I did forget, I'm sorry, to do our welcome to country. So I would like to take this opportunity to acknowledge the traditional owners of the land from wherever you're joining us. Appreciate that sovereignty was never ceded, and pay my respects to elders past and present, and apologise for the embarrassment that happened on the weekend. Without any further ado, I'd like to introduce Professor Nadine Ezard to get things rolling.
Thanks, Chris. Thank you very much for that introduction and for welcoming the panel here today. I'll just remind people to pop any questions as we're going along into the Q&A session, the cute little Q&A thing at the bottom there, and we will have the panel session at the end of my brief presentation. I'm just going to keep this clear, this brief, to run through some work that we did that's kind of sort of informed this discussion today. Again, I also would like to acknowledge that we're on unceded Gadigal land and pass on our sympathies for the weekend. The work that I want to present today is actually not my work solely at all. So this was a study that was conducted primarily by someone called Kate Van Gordon, who couldn't be with us here today. She's moved to the other side of the country, but she did this, the question around this work, and this work was primarily when she was working for us as a registrar. And then Brendan Clifford, who's also online today, I hope, did a lot of the work in writing up the paper. And you can see here also all of our co-authors. So Fiona Fiona McGee was working, and Victoria Malone were both working with us at the time, and Krista Seafried and Duncan Graham were involved in the data analysis and write-up as well. So this is really a collective process, and certainly not my own work. So I'm honoured to be able to present this on behalf of the whole team. So just as the sort of starting point for this work is that we know that around half of the people who use methamphetamine weekly, so frequently in Australia, are women, but yet only 1/3 of people who seek treatment for methamphetamine use disorder in Australia are women. So not implying that everyone that uses methamphetamine weekly has a disorder, but we would be surprised to consider that there would be some sort of gender differentials in that in terms of who might be wanting to seek treatment. So why are women underrepresented in the treatment population in Australia? And we know that there are treatment delays of around average 5 to 10 years from when people first start having problems due to methamphetamine use to when they actually seek treatment. And some of those reasons for that might be self-perceived non-problematic use, which has been demonstrated in some studies, but also lack of confidence in treatment services. And we know also from some of the data that non-judgmental harm reduction kind of services are reported by people who use services to be attractive and seem to be more effective. So what are we doing wrong in this space? What can we be doing better? And just as a starting point, we look at the way that substance use is gendered in our society in Australia. So as a rite of passage or as an active exploration of gender, or in performing your own gender, it's a masculine, almost positive action, whereas for a lot of the work that you see written about women and about the feminine aspects of substance use, it tends to be something about quelling internal psychological struggles, managing and dealing with past traumas, and it's an ineffective coping mechanism. So already we are seeing two different, very quite gendered approaches to thinking about substance use in our society. And I want to just remark, and this is what's written in the paper as well, that when I'm talking about gender, I'm not talking about some fixed binary epidemiological or clinical or genetic difference. It understands gender as a complex social phenomenon that extends beyond classifications and seeks to build the voices of women into contemporary clinical practice. So just bearing that in mind as a starting point as well. So what do? We held qualitative interviews with women who use methamphetamine regularly. The setting was this hospital here, which is an inner city tertiary Australian hospital with a free specialist stimulant treatment clinic. Like, why aren't you coming to see us is what we wanted to know. The eligibility criteria was you need to identify as a woman, be an adult, report using methamphetamine at least weekly, and not be engaged in methamphetamine specific treatment, and be willing and able to provide consent. We recruited people by putting ads up in local free clinics or refuges or other services. There are only 5 services we put the ads up in. People were reimbursed $20 for their participation in the interview. We collected demographic data, did a standardised questionnaire of the severity of dependence scale, which is just a short 5-item questionnaire that kind of gives you a bit of a hint of how much loss of control over use or dependence someone might have. And a score of 4 or greater is considered suggestive of a dependence or a severe disorder. We did a semi-structured interview and then transcribed and analysed them thematically, and 4 of the authors that were listed before were involved in the analysis of that. What were the results? So 11 women with a diverse cultural background, mainly in their 40s, although pretty spread, mainly heterosexual, some spread, around half in a relationship, and all of them reported some sort of injecting, all of them reporting using at least twice a week, and the majority scored positive on this SDS for having dependence or reported dependence themselves. They also reported quite some physical, mental and social harms associated with their methamphetamine use. So kind of indicators that maybe treatment might be beneficial in this setting if it was useful, but this was a group of people that weren't coming forward for treatment. So we asked them about their experiences, and what we found was a very complex interaction between the management of identity, self-stigma and a fear of discrimination. So to start with, women reported positive aspects associated with their use. So in recreation, in socialising, in productivity. And here's a quote from one of the participants who said that it elevated her levels of superwoman-likeness, which is that sense of power that you can get from using methamphetamine. But on the other hand, people felt like they were stigmatized, and they sort of felt like there's a big tag on my head that says I'm a drug user. And for many of the women that we interviewed, the sense of self and self-identity, self-stigma and stigma from institutions was tied up with child custody and how people felt about themselves. And this is a quote from one of the women. There were quite a few quotes, but this one was, no one ever gave me a pat on the back to say, you know, good, we recognise you made major changes because of your children, because she didn't want to be labelled as a bad parent. And none of that was, she didn't feel like any of that had been incorporated into how she was supported through her methamphetamine use disorder. Personal relationships emerged as both a potential research source, but also a challenge. And a lot of women that we interviewed talked about interpersonal violence and coercive control. And here's one quote that we've pulled out. It was in a domestic violent relationship, and the deal with him was if I were to use it, I had to inject. So I started injecting it, and before that I was smoking. It was a control thing for him, being the control freak. So that the methamphetamine use was very much integrated with a coercive controlling relationship. Also, people felt some fear of discrimination and this sense of institutionalized stigma, particularly with criminal justice, police and health services. So with police, you know, I always had issues with them, you know, because of my drug history, said one of the participants. Once they know you're a drug user, they treat you different. To them, I think, you know, you're a piece of shit, so they talk down to you. Even in a domestic violence situations where I've been badly bashed or whatever, they still treat you the same. So this sense that you're being treated differently because you label someone who uses drugs. And healthcare institutions also were not seen as safe spaces for everybody at all times. And there was a distinct preference for trusted continuous care that was integrated with other services for healthcare that were also culturally appropriate. So some of the Aboriginal women that we interviewed particularly appreciated culturally appropriate, acceptable and accessible services, and that were non-judgmental. So here's a quote from one of the participants. It's the place I'd go for everything. They're the best people. I see my psychiatrist, my doctors, my counsellor, my folder's about that thick. The limitations, we've got to be careful what we draw from this study, because obviously it was only 11 people. It was unfunded. We just used passive recruitment for local services. So we were just recruiting people that were prepared to come and talk to us and get a $20 voucher. We don't know what it means for other people that weren't accessing those services, or other people that might have been accessing private services as well. So we had a kind of a narrow range of economic respondents. The cultural diversity was reasonable within the small sample, but again, we could have, it's hard to know how far you can interpret the findings from this. And the gender diversity, we didn't seek to elicit experience of gender diversity or people who identified as trans women or people who identified as non-binary. I mean, there may have been trans women in the group. We just only were asking people who identified as women. And all the interviews were done in English, so that's in itself obviously a limitation. So what are the future directions that we can draw from this? So the first is that we thought was working and addressing stigma. So we can train healthcare providers and we can work with ambivalence around methamphetamine using goals. So the kind of principles that we tend to use around motivational interviewing and not abstinence-based services. The importance of working with social networks came out pretty strongly. So we not only need trauma-informed care training and service design and recognition and referral for intimate partner violence and access to early childhood care and support that's non-judgmental and inclusive, but also potentially exploring ways to include families and friends in treatment planning where that might be positive. So we actually need to build the evidence for family and support network inclusive practice, because we saw before that families could be a sense of support, could be supportive, but they could also be dangerous. So how you actually tread and negotiate that in a way that's positive, we need a little bit more research on, I think. We need to counter the power imbalance of the health service and the person coming to use the service. So lived experience health workers, peer workers, we've been trying to work on in the sector for some time, and we think that probably is important to that. But also looking at other ways of delivering specialist treatment through outreach, community partnerships, telehealth, other modes of delivery. Finally, integrated care came out really strongly. So people wanted to go somewhere where they weren't just going to be talking about methamphetamine, but where they were getting all their physical and mental health care, where they could also get income and social support, childcare support, justice involvement, help with some of all the aspects of people's lives, not just their drug use, and recognising people's intersectionality. So not just gender, but looking at some of the other structural elements that place someone in a position where they can access or not access healthcare effectively or not. And so that might include language, ethnicity, economic access to services and housing. And also that we extend that to training health workers to recognise that kind of structural disadvantage. So I've done this rapid fire review of this piece of work we did because I want to use it as a basis for a discussion with you who are listening online, but also with these my fabulous colleagues here, Suzie and Anna. Please put any questions you might have in the function, and we're going to move on to the first question, which I'll start with Anna and then we'll move to Suzie. What are the most important practical actions to improve women's access to and utilisation of care for methamphetamine use disorder and other methamphetamine use related health issues? Over to you, Anna.
Thanks, Nadine. Thanks, everybody. Thanks for having me. In thinking about how to answer this, I suppose what I kept coming back to is stuff that we know about being really thorough, delivering a comprehensive assessment in an appropriate way, obviously with sensitivities to trauma histories, intersectionality, other kind of structural issues at play. But to be, I suppose, without sounding boring, because we know these things, we see them written, but in the moment of undertaking clinical assessment, really staying with what's happening for that person, I suppose, and really focusing on the harms that they're experiencing and asking those questions about the whole of person. I couldn't help be struck just being reminded in preparing about the absolute, this kind of unbelievable nexus of structural kind of invisibility, particularly with methamphetamine use, in the way that kind of things like ADHD screening, for example, as a part of an assessment and kind of understanding kind of what might be happening for people in that sphere, or kind of adequate psychiatric assessment, et cetera, and considering, therefore, the ways that women are less visible frequently kind of in those kinds of statistics. And so the hysteria factor, I think, for women, in terms of my experience in undertaking clinical assessment, is ever present. Kind of, I think people are concerned about what will be read as kind of hysterical behaviors, as sexualized behaviors, as kind of unwieldy kind of like hysterical elements that are coded, in our culture as particularly negative for women to manifest. And so talking people through in really clear ways around the harms that they're experiencing, making space for those conversations around domestic and family violence, coercive control, and these are things, even sex work, and kind of like all of those, the ways that those issues can be brought together can reinforce stigma, or they can also give somebody breathing space in the way that the questions are asked, and kind of as a whole of person assessment to what's happening for them, what are their priorities, seeking to fill the gaps in the way that we know people can bounce between mental health and substance use kind of factors, in terms of potential psychotic presentation or characteristics. I suppose not making it too messy, just the complete biopsychosocial assessment and giving people space to speak to what's happening for them outside of stigma is it. For me, just to remember always that there's a number of factors that have made it hard for this person to come to hospital. And there's a number of reasons, and really valid structural reasons, why they might not feel happy to share with a stranger what's been happening for them. And so space making, seeking to close those gaps again and give opportunity to ask. And even, I think sometimes, again, in my experience, people don't necessarily make the connection between kind of the level of shame they're experiencing and kind of maybe what their experiences have been, what harm they are experiencing, what they're afraid of experiencing in future. Again, the child protection issue is enormous in that, and that identity factor again, bound up with how we code motherhood and what it means to be female, read as female. Also relevant to trans women. Huge. And so making space in a sensitive way and being really diligent has made a big difference for me, I think, in those settings.
Thanks. And there's a few questions here coming through. Please keep them coming. I'm going to go to Suzie first, and then the questions are very much related to what we're discussing. So maybe we can, Chris, if you agree, we'll ask those questions as well. But I'm going to go to Suzie first. Thanks.
Thanks, Nadine, and thanks for the opportunity to be with you here today. I'm coming to you from Gadigal land. I couldn't agree more, Anna, with what you're talking about. I've been around for a while, and I suppose from a bigger picture point of view, you know, when a couple of decades ago, when we were really starting to see methamphetamine come through and concerns rising in community, we really perhaps did a big disservice in the initial stages to a lot of people by how we characterise the use of methamphetamine in particular. Many of the campaigns early on, both awareness raising and among treatment providers, was very stigmatising, and I actually think served to not only keep people away from reaching out for support, but certainly also undermined the confidence of treatment providers. And so we had to do a lot of work to actually encourage people working in the field that they did have the skills and that they were able to work alongside people. And I think that this has continued on in a way that has provided some opportunities. I think people have recognised that there needs to be some specialist care and some thinking about how we attract people to reach out for support when they need it. And this is particularly so for people who are, for women, people who identify as female, because there are all those layers, as you've quite articulately described, Anna, about roles of caregivers. There's a lot of issues for people around, the care of not just children, but other people in community, and what the implications are for revealing their use of methamphetamine. I think the other thing that we often miss out too, particularly with this substance, is the way in which it works on someone in terms of their experience. And for a lot of people, the feeling of being powerful, as was indicated in one of those quotes, is quite a not only enjoyable, but a unique experience. Many of the women that I spoke with through my own study around the cross of women out on the street was that this was a drug that enabled them to carve out pathways, particularly in the drug economy, in the sex industry economy, that they hadn't previously had access to because of the nature of how the drug made them feel. And so I think that's another interesting aspect, because it is a drug that, from a societal point of view, does tick a lot of the boxes. You know, people can do more, feel like, particularly initially, they can do more, they can achieve more. They feel perhaps some confidence that perhaps they haven't had before. And I think therapeutically, that's, again, coming back to some of those basics of recognising what is the role that this drug plays in someone's life, and really harnessing an understanding about that and being able to use that therapeutically for some really positive gains about how do we build the confidence of people without shaming them, to be able to step back from the shame and the judgment, because there's benefit to feeling in control of your life, being able to do multiple things, and there are a lot of professional people who use this drug in that manner. So I think it's really exactly as you say, and it's about exploring all of those things therapeutically through that assessment about not just what are the harms that are being experienced here, but what are the drivers, what are the things that really make this a benefit to you, and to sort of normalise some of that, and then be able to harness that in terms of change and opportunities for change. So I think, again, some of the learnings too, as we've gone along and from a policy point of view, is how we deliver service treatment. And both that came through, obviously, both the research, your own experience, Nadine, and yours, Anna, is that idea of that opportunistic provision of care, that people might be coming in for one reason to a health service, but that people are actually asking the questions in a non-judgmental way and can actually link them in with some additional support should they want it, and be able to have those conversations in such a way that people feel like it's possible. So I think there's also something about the way in which we fund services from a policy point of view, that there is the opportunity to be a bit more flexible about how we deliver services as well.
Thanks, Suzie. I think one of the questions we've got here is, how can we move away from approaches that focus on individual risk behaviours towards working with a whole person? I think you've both answered that question to a certain extent. Is there anything more that you feel like, either of you, that we feel like we need to add to answer that question? So moving away from individual risk behaviours to the whole person.
Look, from my point of view, it's how we work together with other parts of the service system, but also other parts of that person's network. I don't think traditionally we've done that very well. People don't always have, those who are working therapeutically don't always have the confidence to think about who might we sort of get on the team, and that means community members or social networks. I'm particularly, from a social work point of view, I suppose that's always been part of my approach and my training. You know, there's permission to think in those ways. And I think for some other disciplines and some other teams, that's not always the way. And so I think one of the clear things from my point of view is how you do supervision, case review, and some of those very concrete supports for staff that can build the confidence of people to think more broadly about what's going on structurally. This does play a role. But it is unfortunate in a lot of our services that they are quite siloed. They do work very much on a particular discipline, and it is very much that individualistic. But I think we're learning, we're having it confirmed more and more that the reality is the treatment that we provide is only a small part of a person's experience. And so we've got to get better at educating those around them so that we're not there. When we're not there, they're actually able to practice and support any change they would like to make as part of their own goals, that's being supported adequately out there in the community. I'm not sure, Anna, if you wanted to expand on that too. I mean, working therapeutically, that can sometimes be a bit of a challenge, I suppose, depending on the team that you have around you and their confidence in that space.
Oh, absolutely. But I mean, so beautifully said, Suzie. I think really just bringing into the light kind of all of those factors is hugely beneficial. I also think I'm not sure that I have anything better better how to describe it than how you put it. But I think, yeah, absolutely. Consider the only other thing I thought of from that medical kind of point of view is, again, a visibility comment just around even things like cardiac health, you know, and kind of like understanding that these are structurally kind of areas that women are picked up less. You know, there's less of a light shone on kind of those types of things that I suppose from engagement, kind of like future health, even signaling, I find, even signaling to somebody that I'm interested in all of those things, and having that conversation is kind of opening the door a little bit, linking services. Yeah, absolutely.
Yeah, I agree, and I think that whole of health approach is true. And you mentioned previously, that sex and sexuality, that element, traditionally in methamphetamine service provision, there's a tendency to always talk about those sorts of things with men who may attend. But what we know is that all types of drugs and alcohol are utilised for most people to facilitate sex or intimacy. And I think it's really also, bringing into that sexual and reproductive health is hugely important, and feeling comfortable to do that. You might not be an expert in that area, but working closely with your sexual health and your reproductive health colleagues to feel that you're able to ask those questions sensitively, if appropriate, and to sort of see that whole person, because I think that drugs and certainly methamphetamine can play a significant role in people's sexual expression and intimacy. And so if changes are going to be made, then that needs to be explored as well as a way of supporting people to make the changes that they themselves have identified. Yeah.
And you so rightly commented, Suzie, as well about the empowerment factor. I mean, that is huge. And it means that the conversation can look like, you know, my methamphetamine use means that sex is more fun, you know, and is that okay? And is this a conversation? If you're worried about it, like, do we engage sexual partners? Kind of, do we engage the person that you've been having the checks with and let them know that this is happening for you, you know, et cetera, et cetera? Or is there some other kind of coercive element where a performative sexuality, you know, for women, people identifying as female in the community are pressured to perform, and exploring therefore kind of all of the shades, you know, and bringing it into the light, given these kind of like compounding stigmatizing factors for the substance. Yeah.
Which segues nicely into another question that I really like, because I can't answer it. Could you talk a bit more about what family and social network inclusive practices might mean, and what research might look like to build that evidence base? So you've talked about sexual partners or clients, but who else would we be talking about there?
I'm going to jump in just about, again, it's just a really nice kind of, I guess, back and forward with parenthood, you know, and caring responsibilities, where it's like there's a lot of coding around what it means to be a kind of effective parent, and read as a positive parent in the world. It's a lot about productivity and kind of managing enormous tasks that are burdensome and tiresome for most people, you know. And so if methamphetamine is playing a role in your better being better able to kind of manage all of your responsibilities, that's you know, really understandable. And so therefore just having those really explicit conversations. Obviously in a clinical role there's disclosure required around kind of what reporting requirements are, obligations are, but I think again ensuring that trust and rapport guide those, you know, not shrouding them, you know, and kind of engaging adults about what they look like and why, you know, and therefore taking the shame out of it. Again, there's enormous possibilities. I mean, imagine if somebody, for example, was needing to, felt that methamphetamine made them a better effective parent because they could get across all the things they needed to. Stopping that because they were equally concerned about it in other areas of their life might mean, what are the adjunct supports that are able to be put in place that mean that they're not unduly stretched, you know, and able to maintain face, you know, and maintain that identity piece around being a parent amongst their peers, to their children, to their family. And I mean, it asks this broader question, which is never easily answered, around what are DCJ doing to support parents, you know, and how kind of well resourced that is, beyond being a kind of you know, more mechanistic role. Yeah.
Yeah,
that's great, because I'll just jump in because there is a specific question from Sarah about one, you know, highlighting how important the parenting and caring responsibilities is for many women, and whether any of us have some thoughts about how we could health could better partner with DCJ and child protection to better support women and therefore their family. And I don't know if you noticed, I would actually add early childhood. I mean, all that work that June Oscar has done up in Western Australia, and many other kind of other examples that we can point to about the importance of high quality early childhood care as well, rather than just waiting to criminal justice and child protection's got involved. But I'll hand over to you, the experts, on this question.
Well, look, I just think that there are some really good examples of working better with DCJ. I think there has been some shifts and changes. There's still probably a lot of work to be done, but I would really encourage all people working in our field to ensure that before a crisis hits, that they've actually reached out. They know who their DCJ people, their child protection.
For people that mightn't be joining from New South Wales, do you want to just explain who DCJ is?
Departments of Community Justice. So these are the child protection people. So you're quite right, Nadine. Anywhere across the country, it's finding out who in your area is working in that space for around child protection and child support, finding out who they are, sitting down, having a cup of coffee with them, linking in before, you know, there's some sort of tension or issue happening, because trying to speak the same language, which is about, ultimately families better together, which is, I think, where we're all striving to be. And certainly those who attend treatment services are striving to what they're striving to do. And in some cases, their belief is that they do better when they are using their substance of choice. And in this case, methamphetamine, does what it says on the packet. It does enable people at times to do more and feel more efficient. Whether or not that is borne out in reality, that's where people are at. And so, again, it's tapping into the drive. What are you trying to do? Well, I'm trying to do better. Okay, well, that's great. Let's talk about that. But it's getting connected in with those services early so that they understand what your role is and you understand what their role is. And I suppose too, it's about thinking more creatively about what you can provide. When you have a service, is there a place where children can go while they're seeing you in a session? I mean, do they have the supports around them that would facilitate their attending for treatment? What does that look like? And how do we also allow for the engagement of other parts of the family so that they know the best way to support that person when change is happening, and when things are challenging. So you talked before, Nadine, about that more family inclusive approach. It's also considering how do we help those to also get their needs met, because that's frequently the experience for external people, whether that's friends or family. They're desperately trying to have change happen, but they're often not looking after themselves either in that moment, because they don't see that, what is their role in this experience. And so it's, I suppose, too, having, if not within your own service, it's having the connections with external services that you can refer others to, because their own distress can compound a difficult experience for the person who's using a substance. And so it's trying to manage some of those things as well and ensure that everybody's getting the support that they need at the right time.
Thanks. There's two other questions specifically around childcare roles. So the first is getting to the clinic because of having small children and no support. And then the second is just simply women more likely to be prime carers and therefore reluctant to access services because maybe you feel fear of losing children or lack of childcare, the straightforward things. So there's sort of looks like there's some basic things we could be doing in that space, but how do we help people get trust?
Yes, I think that's hugely problematic and it continues to be. But I think it says something about, I think drug and alcohol or AOD treatment tries to feel like it needs to do all of these things. And I think that's problematic. I think the addressing of stigma, particularly when it comes to substance use and related parenting and caring roles, there's a role for all health and welfare professionals to actually play an active role in trying to address stigma and discrimination of people who use substances. And I think that's where we need to do better. I think for a long time, AOD sort of said, we've got to address this and we're going to fight for this. And that's one part of it, but actually we can't do it on our own. And therefore we need, multiple agencies to start to help us to address that issue, because it pops up all over the place. And I don't think that it's possible for us to address it solely on our own. And again, it gets back to this idea of what are the drivers for substance use, for, aside from pleasure and experiences like that. They are routinely about trying to fit in and do the right thing in society, ironically. A lot of those drivers are about I'm trying to manage things, or this helps me to do that better. So I think it's about thinking beyond just what AOD needs to be doing, but also how do we partner with childcare or, you know, how do they we get to know them a little bit better so that they understand what we're trying to achieve. And some of those partnerships, you know, I've seen work in other states, as well as New South Wales, where you're partnering with childcare providers. You're able to provide that childcare, and then also other caring roles that people may have. You ensure that person can get time out and respite so that they're able to address whatever issues that they would like to address in the context of AOD treatment.
So we've got the question here on how do you balance supporting a woman using methamphetamine with harm minimisation when you are also a mandated reporter and you're trying to keep a therapeutic relationship. Anna, do you want to take that one?
I'll take that one.
Yeah.
When Suzie was speaking so beautifully before, I was thinking of a case from kind of my history where a young woman had given birth in hospital and was a known kind of methamphetamine user, and there was a planned assumption of that child into care. It was her 5th child, and her 4 previous children had previously been assumed into care. And my input was, I suppose the question was asked of me kind of like, what should we do? This woman is acutely distressed. We're checking on her all the time, you know, but we believe that she's kind of becoming kind of hugely dysregulated and throwing things, and she's really distressed. And then she leaves the ward, comes back after about an hour and is really calm, and we think she's using off the ward. And it was a question, I bring it up just, I felt really sad for that young person, and I also really heard the kind of distress of the clinician in that moment, that they weren't sure kind of like how to keep everybody safe today, you know, in this moment. And I suppose I jump back to the trust piece, where I think that young person, the young woman who'd just given birth, would naturally have been really distressed. You know, having had 4 children previously assumed into care, the occasion of that child's birth was likely laden with grief on many levels, and fear on many levels. Apart from the fact that birth is a hugely traumatic event anyway in one's life, and the clinicians at hand had failed to account for all of these human factors that I think would have, like, it was a missed opportunity to build trust around the quality of therapeutic engagement in the first place. You know, it wasn't necessarily the relevant question about whether she was kind of leaving the ward in that instance, you know, to use crystal methamphetamine. I mean, I couldn't help and reflected to the clinician that I too would have wanted to leave the ward to have some space from that kind of, you know, the particularly narrow focus of the biomedical and the kind of the way that the child protection mechanisms can be employed in blunt ways when people are afraid. But that fear piece is real, you know, for everybody. And so kind of doing, again, due diligence, kind of asking all of those questions, paying attention to that whole of person, it is the possibility to, I mean, I recognize it sounds repetitive, but that opportunity to build trust around seeing someone and really seeing them where they are and accounting for the kind of realities and complexities of the situation they find themselves in is the best starting point before you even come to the kind of substance use piece in that moment. I don't know if that's a great answer, but it's one that is from my heart. You know, it's yeah.
Yeah.
Thanks. Suzie,
Yeah.
did you want to add something?
Oh, look, I totally agree. And I think, you know, what comes through for me, and having been in those situations therapeutically, is how do we start to work a little bit earlier? I mean, it is, you know, it's often the case that women who are pregnant will stay away from services for exactly that reason until it's very late in the piece. And that says a lot more about the lack of trust that or what we've not been able to do to create some level of trust, or to reach out to them. And I suppose it just says something about, not only our stretched services, but how do we start to work better together, and for the better outcome for both for the family, for the child, the woman who may be giving birth, but also her other connections, whether it's partner or extended family. That's a sort of constant piece of work, and I think that's the other issue of our systems often, is that they dip in and dip out, and so you're often only there in those very crisis moments, as opposed to taking the opportunities when there might be less of a crisis happening, and you're able to do more of that in-depth work that may need to be done in order to create a safe space to encourage confidence in parenting. I mean, parenting is a challenge for everybody who's experienced it, and it requires lots of support. And so I think that's another interesting thing, a gendered thing, is this perception that people who are able to give birth naturally have this mothering, or this care, instinct, and I know that's that's very unhelpful, actually. And so what do we do better as a society and a broader health and welfare system to encourage people to be connected with others, to so that when those crisis situations happen, we've actually laid down some of the groundwork to mitigate those, so that it doesn't come to that point. I think it's also about the language we use, the creative solutions that we search for. That's really important, and that takes also a workforce that feels well supported too. I think that's another, a bit of a random piece, but I think also, for anybody that's watching today, is also thinking about your workforce, the colleagues that you work alongside. How are they travelling? Because the reality is, particularly in those situations that you describe, Anna, if you're a good cohesive team who feels well supported and well supervised, you're in a lot better position to respond appropriately. I think you're on mute, Nadine.
I might jump in here. Nadine, we can't hear you, I'm sorry.
Apologies. I was just jumping in with another question around how is methamphetamine use and harm gendered. We've already touched on a lot of this. We've talked about some of the contexts and rationales that women might give for using methamphetamine that might be gendered, and also some of the harms that we see, particularly the parenting one, which seems to jump up primarily, but also some of the missing of some of the other harms around sexual and reproductive health and cardiovascular health. But maybe, is there anything more that you'd like to add, Suzie or Anna?
Well, from my point of view, just to say that, particularly as a result of the research that I did a number of years ago now, what came across, and certainly there's lots of good research evidence that talks about roles of women, particularly if we're talking about, we've talked a lot about those caring roles, and they're not just for children, but also for parents or elderly parents or other people in communities. Certainly street-based settings, there's a lot of caring that goes on, and feelings of responsibility, and I think that has implications for how treatment is delivered, how treatment is received, and the role that substance use can play for women. But also just harking back to that idea of power. I mean, certainly in street-based communities or drug economies, women's roles are traditionally, as they are reflected in society, a lot lower down, and there's a lot less power evoked there. The other thing to really think about, and this comes up time and time again, both in the research literature and certainly in the therapeutic experience, is initiation of substance use. For, this is a generalization, of course, but for a lot of women, it's through intimate personal relationships, through trusted relationships that substance use is initiated. And this is often the case too for methamphetamine. And I think that's an important piece to consider when speaking with people coming through the door, which is how their use was initiated and what that means for them, not just in terms of their own identity, but how they relate to others and how they navigate relationships more broadly. I think that's an important piece of work, both therapeutically, but also to consider, particularly when you're talking about some of the domestic violence or coercive concerns that may be going on, which can be can be part of the reason why it's so difficult and challenging to step away from substance use. Not sure what Anna's experiences have been, but
no, just the same, Suzie. I think it's I would say in closing on it that it's a particularly potent intersection of missed opportunities in terms of the treatment that we provide. And so being aware, being mindful of that power piece is all the structural dimensions, as well as the more individualized aspects, and encouraging people to kind of locate themselves within a structure is sometimes work that takes encouragement and support. And so the mindfulness to the potential risk in missing any bits of that in terms of enfranchising someone to treatment, but also in their own lives, and kind of stepping into the driver's seat around it is hugely powerful. Thank you.
Thank you. And one last question for the panel. And again, we have touched on this a little bit, but a lot of what we've been talking about, you could say it applies to all treatment of all substance use disorders. So how's treatment for methamphetamine use disorders for women different to the treatment of other substance use disorders?
Well, from my point of view, I think one of the key differences is the nature, the way in which the drug works, the action of the drug. I think there are differences there which are very appealing. If you're talking about what is rewarded or valued in our current society, which is do more, look better, have more sex, all of those sort of aspirational things that are pumped into our lives. I think the rise of social, dare I say it, social media, which I know very little about, as many people who know me know, but I'm not immune, and I think there's lots of intersections between scrolling, looking at things, stimulant drug use. I mean, these things they do go together. So I do think understanding the action of the drug, how it works, how people use it in their day-to-day lives, and those feelings of feeling the confidence, I think they are very significant and important things that if you're working in this space, it's good to have a good awareness of. And certainly in my experience therapeutically is sharing that information with the people coming through the door can be huge light bulb moments. So yes, just as that therapeutic trauma-informed thinking about the role, the drug, etc., is important, explaining how it actually works has lots of moments for people where they just go, oh, right, that's why that, oh, okay. Oh. And I think, so as part of the therapy, it's being able to articulate and help people to understand how this particular substance works and why it is so appealing is important.
Thank you. Anna, anything else you'd like to?
Not really, other than just agreed that actually some of the structural stuff and the power stuff in our world isn't visible really to people until it's kind of like fleshed out, and in a way it provides, like, an assessment around this stuff provides an opportunity to kind of highlight how that's working in somebody's life, and it can again hopefully put them in the driver's seat around kind of where they want to be and what they want, and acknowledging the kind of the pressures to perform in particular ways. Very well said, Suzie. Thank you.
Thank you. Before I hand back to Chris, I'm just going to acknowledge and thank the participants in the study, my co-authors, co-presenters here today, and Dora and the Daria team, and Chris, who's chairing. Back over to you.
Thank you, Nadine. Thanks, Anna and Suzie as well. And thank you to all of you for joining us. Next month's Daria is on November the 20th, and we'll be focusing on cannabis and opioid treatment programs, their intersection, treatments, overlap, attitudes, and so forth. So should be a very interesting session. So please join us then. Otherwise, thanks for attending and see you next time.
Thanks,
Thank
everybody.
you. Thanks. Bye.
Thank you. Thanks so much. Bye.
Bye.